Good afternoon, everyone, and welcome to the webinar. My name is Kieran Stevens, and on behalf of Williams Medical, I'd just like to take this opportunity to welcome everyone to this webinar on simplifying ABPI, a step-by-step guide. This webinar is presented in partnership with Huntley, and we are delighted to welcome Kerry Nyland and Gavin Dummett today. So thanks for joining us both. I'm sure you'll both introduce yourselves very shortly. A few bits in terms of housekeeping. So this webinar is scheduled for 1 hour. We'd like to invite your comments and questions throughout the session. So if you do have a question, please use the chat function, which will be at the top of your screen. A lot of people have already used it, which is brilliant news. There will be plenty of opportunities to tackle these questions throughout the session. And we also have Oliver Hannes on hand to help us to moderate the chat today. So thank you, Oliver. And finally, this webinar will be recorded and will be available within a couple of days after the session. We'll also share some of our useful resources and content from the session as part of our post-event communications. So without further ado, I'd like to hand over to Kerry to start the session.
Hi everyone, thanks for joining us today. My name's Kerry. I work as a clinical support manager for Huntley Healthcare, and I'm also a podiatrist. Gavin and I will talk you through simplifying ABPI today. Gavin, would you like to introduce yourself as well?
Hi, I'm Gavin Dummett. I'm the Senior Global Product Manager for Vascular and Patient Monitoring at Huntley. I've been with the company 20 years. So if you have any product queries, please put your questions in the chat. Thank you, Kerry.
Thanks, Gavin. Okay, so let's make a start. Okay, so the focus of the session today is going to be on how to do a manual ABPI, and this forms part of what we call our SOCS off training that we run quarterly at Huntley head office and at various events that we attend. So we've got a step-by-step guide that you can get from the Huntley website in the Academy section. So we'll either add that as a link in the chat or we'll send that to you post-event if you'd like to register and get further info. And also just to get a quick mention in, we're running a vascular masterclass here at Huntley head office on the 21st of March. So if anyone would like to come along to that, we'll make sure you've got details of that as well. So let's get started. So measuring and calculating your ABPI. The simplest way of explaining ABPI is that you're comparing the blood pressure in your arms with the blood pressure in your ankles, and you're going to calculate a ratio by dividing the highest ankle pressure by the highest brachial pressure. The ratio is going to indicate the severity of any PAD, with a ratio of 0.9 or lower indicating PAD, and the lower that goes, the worse the disease. But on the flip side, you can also get a really high ABPI ratio of 1.3 or above. And this indicates that the vessel is calcified, it's stiff, and it's difficult to compress with the blood pressure cuff. So it elevates your blood pressure reading. And you'll see this a lot in patients with diabetes, for example. But we'll explain a little bit more about that as we go along. So we'll go through the rationale for ABPI, what's it for. Gavin's going to talk us through the equipment that you'll need to do an ABPI. We'll go through preparation of your patient to ensure accurate results, measuring and calculating the ABPI, Doppler waveform and sounds form part of the assessment, interpretation of the results, re-examination, factors affecting the ABPI, and we'll finish with a little interactive quiz just to see if anyone's still there. So this is just a short animation. It shows you what happens when you occlude the artery when you do an ABPI.
Holding the probe at about 45 degrees to the vessel, the Doppler generates an audible sound and the waveform on the screen shows a direction of flow. In a healthy person, the arteries in the ankle have blood flow in the forward and reverse direction. By applying a blood pressure cuff to the ankle and inflating it over systolic pressure, the blood flow is stopped and the sound disappears. The cuff is then deflated slowly, and the point at which the blood flow starts and the sound is heard is the systolic pressure.
Okay, so we'll talk you through how to do an ABPI, and there'll be some more videos coming up there. So what's the rationale for ABPI? So firstly, to confirm or refute PAD, and by PAD we mean the narrowing or blocking of the arteries, in this case the lower limb, and it's usually caused through atherosclerosis, where you get fatty deposits and plaques building up on the wall of the artery. One of the first symptoms is often intermittent claudication. Patients will report a cramping or a vice-like pain in their calf, usually after walking a certain distance that's relieved by rest. Usually felt in the calf, that being one of the main muscle masses, and that needs a good supply of oxygenated blood. But it can also be felt in the thigh or the buttocks, depending on which artery is affected. I've heard people refer to it as angina of the legs, which I think is a good way of sort of understanding and describing that ischemic pain that you get. So as the disease progresses, it can move towards a chronic limb-threatening ischemia, and this indicates a more worrying blood supply to the lower limb. Patients may report rest pain, which is typically felt in the feet and the toes, and it can be accompanied by tissue loss and gangrene. It's for the patient, and they'll often report needing to hang their leg in a dependent position. If you elevate the leg, it will go pale very quickly, and when you lower it back down again, you'll often see that dependent ruber, that ruddy red colour. And that's the result of vasodilation of the vessels. They're not working in the way that they should. So those types of patients will obviously need vascular opinion as to the options for restoring blood flow. So ABPI can also help determine the etiology of a wound. So is it an arterial leg ulcer, a mixed leg ulcer, and by that we mean of arterial and venous origin, or is it a venous leg ulcer? So remember that the ABPI is an arterial assessment, so it's not going to confirm venous disease. That's going to be largely determined on your clinical presentation. You're looking for those signs and symptoms associated with venous hypertension, that hemosiderin staining, edema, venous eczema, and so on. Current guidelines, the National Wound Care Strategy and the Wales Leg Ulcer Standards advocate that patients presenting with a leg ulcer should undergo ABPI. In the absence of any red flags, patients can go into mild compression of 20 millimeters of mercury at the ankle as a holding therapy until they've had full vascular assessment. But we know that this is suboptimal for venous leg ulcers, that they need to be in strong compression. So the ABPI can help guide with compression levels. And in the absence of any other contraindications, an ABPI of 0.8 to 1.3 would mean that you could use strong compression. 0.5 to 0.8 may be suitable for reduced compression, but would likely be under the recommendation of a specialist TVN. So the ABPI is now also increasingly recognised as a marker of cardiovascular risk. If your leg arteries are furred up, it's likely that the other arteries are too. Atherosclerosis is systemic, so hence these patients are at higher risk of heart attacks and strokes. So the sooner you can recognise that, the sooner you can look at meds management, getting them on an antiplatelet, statin, managing any hypertension. Smoking cessation is really, really important with this patient group. So it's looking at those modifiable risk factors. For those with claudication pain, exercise is recommended as the first line treatment, as it does help to develop your collateral circulation. So in simple terms, if your motorways are blocked, you can use your A and your B roads. So some of you may have heard of the 3 Ps approach. So the simplest way to approach your vascular assessment is to use your 3 Ps, your pulses, phases, and your pressures. Your ABPI is just part of that bigger clinical picture. So firstly, see if you can palpate the foot pulses, the dorsalis pedis pulse and the posterior tibial pulse. The dorsalis pedis is on the dorsum of the foot, and if you dorsiflex the foot, you may find it easier to find. And with the post-tib pulse, you'll find that behind the medial malleolus. So inverting the foot can help you find that. Use 3 fingers to do it. Don't use your thumb because you might pick up your own pulse doing that. And count it for 10. If you can't feel anything, that's absolutely fine. If you're confident you can move upwards, you can check the popliteal pulse and the femoral. But if you can't feel anything, that's fine. Just record it as non-palpable and move on. So next you're going to get your Doppler out and you're going to check your phases. You're going to be listening to the pulse and you're going to be looking at that waveform. Is it a triphasic pulse? Is it a biphasic? Or is it a monophasic pulse? Sometimes you'll hear the triphasic and biphasic grouped together as multiphasic. I think that's just to make it, simpler, so you're not getting too stressed about which one is it. Lastly, you'll add in your pressures. So you'll add in your ankle pressure or you're adding a toe pressure. So it's about putting that together with a good history taking and their clinical presentation, and that will help inform your diagnosis and your treatment. So why add Doppler? So as we said, pulse palpation is the first thing you can do. You've got your patient on the couch. You can easily be asking them about their history and feeling for pulses while you're doing it. But it is subjective and it's dependent on the experience of the clinician. Like anything, the more you do, the more confident you'll be at doing it. So using a Doppler, though, it is a more objective way of measuring, and the ABPI using a Doppler is the gold standard. You do still sometimes see people doing ABPI using a stethoscope. I've not personally ever tried that myself, so if any of you do that, it'd be interesting to hear your comments in the chat. If you have an elevated ABPI, you may be suspecting some calcification of the artery, and this is very common in patients with diabetes and renal disease. So looking at your Doppler waveforms alongside your ABPI can help with your clinical picture. So Gavin, are you okay if I hand over to you at this point for the next few slides?
Yes, that's no problem, Kay. Okay, so when it comes to the probe frequencies, so the rule of thumb is the lower the frequency, the deeper into the body the signal goes. So lower the frequency, deeper the optimum range, and then obviously you can distinguish by the size of the head of the probe as well. So a typical example, 10 megahertz probe would be used. It's got a very low depth. So basically it's fingers, toes, your face, and then a 2 megahertz probe would be a deeper depth, then, which would be more for obstetrics, monitoring a baby. Next slide, please. Okay, so this is our probe range. So the 4 megahertz probe is more for the very deep lying vessels. A VP5 dermis limbs, lymphatic limbs, where it's harder to get a signal. So you'll find this in the ABPI kit. And you can also use this then for the popliteal and femoral artery if you're doing a complete assessment of the lower limb. The VP8 is sort of your all-round probe. Could be used for most applications. And the EZ8 then is a wider beam probe. So it's an 8 megahertz and it's got a slightly wider range. We've designed this probe purely for doing ABIs. And what happens is when you sort of occlude the vessel, the artery, basically you could lose the signal if you've got the smaller head probe. With the EZ8, with that wider beam, you've got less chance of losing the signal once you release that pressure then, and that systolic pulse comes back in, you're guaranteed then sort of to get that signal back. As I mentioned earlier, VP10 is sort of very, very fine vessels, such as your fingers, your face, and maybe your toes as well. Next slide. Okay, so we've got a range of Dopplers from audio only to directional and then to our full waveform Doppler. So we supply an ABPI kit and a TBPI kit. So the ABPI kit will contain everything you need to do an assessment. Whether that's the different size cuffs, the Doppler itself, the recharging kit, the SFIG, and then the documentation required. As you can see with our kits, you always get the waveform Doppler, and that's what we always recommend, because obviously it gives you the added reassurance of the visual confirmation, which is proved in studies can be very, very crucial. Okay. Next slide.
That's back to me, yeah.
Okay, thank you, Kerry.
Thank you, Gav.
Thanks.
Okay, so we're on to preparation of your patient. So preparation of your patient is really important, because if the patient's not prepared correctly, then incorrect readings may be recorded. So sounds obvious, but explain and reassure the patient of the procedure. If your patient's got a leg ulcer, they're possibly going to be quite nervous about the idea of you putting a blood pressure cuff anywhere near that wound. So could be an idea, if they've got a good leg, to maybe do the good leg first, and then just let them know what that feels like, and then move on to the other leg. But just reassure them that if it's too painful at any point, you can whip that cuff off really quickly. Patients should refrain from smoking for at least 10 minutes prior to the test, because it can cause vasoconstriction. Make sure the room is a nice, comfortable temperature, ideally about 22 to 24 degrees Celsius. Allow the vessels to dilate. If it's too cold in the room, the peripheral circulation can shut down, and it can be really difficult to get readings. Make sure you remove any tight clothing from the arms and the legs to prevent a tourniquet effect. And same goes if they've got a jumper tied tightly around their waist, that can affect blood pressure readings as well. So that's to loosen that as well. You can cover any open lesions with cling film or a clear dressing. And it's important that you rest the patient in a supine position for at least 10 minutes. Now, I know a lot of patients are not going to be able to lie flat. It is a big problem. If your patient has got any respiratory issues, COPD, or if they've got any spinal stenosis, for example, lying flat is going to be a no-no. So there are a couple of things that you can try. You can try getting them into more of a V position, put some pillows under the head, put some pillows under the knees. What you're trying to do is just get the legs in line with the heart, just to try and equalize the pressures as much as that disease will allow. But just be aware that it may elevate your pressures, and just document that in your notes, and just be aware of that when you're looking at that clinical picture. So as the ABPI is an arterial assessment, it's important to familiarise yourselves on the sounds heard through a Doppler. So a normal artery has a clear pulsatile sound, whereas a vein has a windy, almost continuous sound. So we'll just have a listen to a normal artery. Okay, so it's a nice healthy artery there. It's like a train, da 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 da. So we just have a listen to a vein. So it's like a very windy, whooshy sound. So it can sound very similar to a diseased artery in a monophasic pulse. Gav, you've got a good tip, haven't you? If you're not sure if you're on an artery or a vein with your Doppler probe, there is something you can do.
Yes, that's right. You can hold your breath for a couple of seconds, yeah, and that will sort of phase everything out, and you can make sure then that you get a nice clear artery signal.
Thank you. Yeah, you taught me that. Good tip. Okay, so we're just moving on to the first of the videos as to how to do an ABPI. So you're going to start with your brachial pressures. So let's just have a watch of this.
Using the Doppler, first the brachial systolic pressure is determined in both arms. Making sure the patient is relaxed and comfortable, the cuff is placed around the arm. Palpate the brachial artery and then apply gel. Using the Doppler, locate the artery and hold the probe about 45 degrees to the skin. Inflate the cuff until the sound disappears. And then slowly deflate at around 3 millimeters of mercury per second. The point at which the sound returns is the brachial systolic pressure, which is then recorded.
Okay, so you need to inflate the cuff about 20 millimeters of mercury over when you last heard that sound. So if, for example, you lose the sound at 140, inflate to 160, and then slowly start to release back down.
Using the dot.
Then you're going to do your left arm.
Repeat the procedure on the other arm and use the higher of the two readings in the calculation. If the readings are significantly different, this suggests arterial disease.
Okay, so that's an important point. If you're getting a difference of more than 15 millimeters of mercury between the arm readings, it could indicate subclavian disease, and that will need flagging up for further investigation. I think also worth mentioning, if you find it difficult using the brachial pulse, sometimes you can use the radial pulse instead. So if a person's got quite a short arm, the cuff can sometimes come down a little bit further, making it difficult to get the gel in that crease and get the probe over the pulse. So if that's the case, then you can try the radial pulse if that makes it easier for you. So probe positioning. So probe positioning is really, really important. So make sure you've got plenty of gel to make that contact. You need to be holding your Doppler probe like a pen and at a 45-degree angle towards the heart. So take your time to sort of position, get the best sound and the signal that you can. Just reassure your patient that sometimes it does take time to find the pedal pulses. That's quite normal. But yeah, just a fraction of a millimeter can change that sound or signal completely. So just take your time to find the best signal before you start inflating the cuff. So you need to assess two arteries in each foot, and this is usually the dorsalis pedis and the post-tib pulse, but the perineal pulse can also be used, and that's especially useful if the patient has got diabetes, because the perineal artery is less likely to be calcified. I'm not quite sure why that is. If anyone knows why, please pop that in the chat. So you've taken your brachial readings and you're going to record the highest of your brachials, and then you're going to take the ankle pressures.
Then the ankle systolic pressure is determined from both the dorsalis pedis and posterior tibial arteries. The cuff is placed around the leg just above the ankle. Gel is applied and then using the Doppler probe, locate the dorsalis pedis artery and optimize the signal, holding the probe at about 45 degrees to the skin. Keeping the probe still, the cuff is inflated until the sound disappears, and then slowly deflated until the sound returns. This is the ankle systolic pressure and should be recorded.
Okay, so if you're on the dorsalis pedis on top of the foot, it can be very easy to slip with the probe and miss that sound returning. So try and anchor your hand as much as possible to prevent that happening. Once you've done it a few times, you'll get used to your own way of doing it and where you position yourself. You can also put the cuff on upside down if you want to, and so that the tubing is going up the leg, and so that can stop you getting too much gel in the way of the tubing. So yeah, just another little tip there.
Then the ankle
So then you're going to move on to the post-tib pulse.
Repeat the procedure for the posterior tibial artery. The higher of the two readings is then used for the ankle brachial index calculation.
Okay, so you're taking the two pulses, you're going to take the highest reading. Another important thing to check is that there's enough room for the cuff to inflate. If your patient's got a really heavy edematous limb, the weight will make it harder to inflate the cuff. So see if you can get a finger underneath the cuff before you start, just to check it's got room to expand. If not, perhaps see if you can get something under the heel just to create some room there. So to calculate your ABPI, you're going to take the highest ankle pressure and divide it by your highest brachial pressure. Huntley kits come with these little calculator wheels, which are quite handy to use, but you can also use your phone. So just remember, if you remember leg over, so you're going to divide the highest ankle pressure by the highest brachial pressure. So you do the calculations for both sides. So in this example, if we look at the right side, the dorsalis pedis is the highest reading at 85. So you'll take that and you'll divide it by the highest brachial, which is 150. And that gives you a ratio of 0.57. So on the left side, the post-tib pulse is the highest reading. So you take that as your highest and you divide that by your highest brachial, and that gives you a ratio of 0.8. So if we remember those ratios as we go to the next slide, it does give a guide to compression. So yeah, as I said, if you remember those values, you can have a look at what this means in terms of compression therapy. I mean, remember, of course, that your ABPI is just part of your holistic assessment on its own. It's not a diagnostic tool. So we had, if we remember, on the right leg, a value of 0.57. So if you look at that first column there and scroll down, you can see that 0.57 indicates moderate PAD. So it may be suitable for reduced compression with specialist advice. On the left leg, we had a value of 0.8, and even though that indicates mild PAD, you could still apply strong compression as long as there's no other contraindications. So in this case, you could potentially have a situation where you could use reduced compression on the right leg and strong compression on the left leg, but that would probably be under specialist tissue viability advice. So you may be using your ABPI as a guide to compression levels, but you may also be using your ABPI for onward vascular referral. For example, your patient may have a deteriorating wound and signs of ischemia, and this referral form is from the National Wound Care Strategy. And like many guidelines now, it's adopting the Wi-Fi classification tool. So for those of you who aren't familiar with Wi-Fi, this stands for wound ischemia foot infection. And it's a really useful classification tool when looking, lost my thread there. It's a really useful classification tool. It looks at the risk of amputation and the benefits of revascularization. So again, it's going through your 3 Ps, your pulses, your phases and your pressures. So you're going to calculate a Wi-Fi score, and you can get apps on your phone to do that. So I'm not going to bog you down with too much detail there, but I just wanted to show you some of the different ways that you might apply ABPI and might use your ABPI. So how often should we repeat the ABPI assessment? NICE states that Doppler studies should be repeated every 6 to 12 months or sooner if clinically indicated. So it's going to depend on your patient. If you've got a wound that's deteriorating or a new onset symptoms, it would be sensible to repeat the assessment. And in the event of a leg ulcer reoccurring, don't assume that it's of the same etiology. Repeat your assessment. Factors affecting the accuracy of the ABPI. So there's several medical conditions that may affect the accuracy of your ABPI measurement. Patients with diabetes may have associated calcification of their arteries, which could artificially elevate the ABPI. Same with CKD, and they may also have fluctuating blood pressure, which again could affect the accuracy. Patients with rheumatoid arthritis may experience vasculitis, where the vascular system becomes inflamed and it's very painful. If a patient has active vasculitis, they're having a flare, it's likely that ABPI is going to be way too painful. So you may need to see them settled on steroids and immunosuppressants before you could even attempt that. Arteriosclerosis just refers to the hardening of the arteries. Atherosclerosis comes under that, and it can make it very difficult to compress the arteries, which again can lead to falsely high readings. And sometimes the vessel is completely incompressible. If you're inflating the blood pressure cuff up to 220 millimeters of mercury and you're still not losing the pulse, we generally call that incompressible. For patients with cardiac arrhythmias, the main problem is missing that pulse returning. So it's really, really important when you deflate the cuff to do it really slowly to make sure you're hearing that first sound return. I've got a Svig here. Svigs are all different. The ones that we've got come with a clicker on the back. So you click up to inflate, you click down to deflate. The way I deflate is I've usually got my finger behind the trigger and I just come back down really slowly. If you're pushing on and off the trigger like that, you're not going to get the slow controlled deflation that you need. So again, it's just something that comes with practice. So with peripheral edema, that can elevate your ankle pressures. And the same with lipodermatosclerosis, just about said it there. So with that, you can get like a fibrotic hardening of the skin, which again can elevate your ABPI. So the presence of those conditions doesn't mean that you can't do an ABPI. It just means that you just need to review those results with caution and consider them in the light of the patient's presenting history. If in doubt, just refer on for further investigation. So there's several factors that can affect the accuracy of the ABPI. So as we mentioned, the room temperature. If the room's too cold, it can cause vasoconstriction. Goes without saying, if the patient and clinician are anxious and unrelaxed, then it can raise your BP. So yeah, make sure the patient's got information in advance what's going to happen. And obviously, as I said, if they've got a leg ulcer, just reassure them that they can stop the test at any time. Incorrect position of the patient, as we mentioned, if they're not supine, if they're not completely flat, you are potentially going to get elevated ankle pressures. But, you know, it's not always possible. So if you can try and get them into more of a V shape, then do that instead. Inappropriate gel, this is really important. You need to be using the correct ultrasound gel. Don't be tempted to use other lubricants because you can get like little microscopic air bubbles in them, so you won't get as good a signal. So if you're trying to pick up pulse in an already diseased limb, that can be hard enough anyway. So by using the wrong gel, you're just going to make that harder for yourself. Using the wrong size cuff. Our cuffs come in two sizes, a standard and a large. That's the standard one there. About 80% of the cuff should be covering the limb. If you're pumping up the cuff and you're hearing that sort of sound, it's popping off, then it's possibly too small. So move up to the next size and try that one. And as we mentioned earlier, the position of the probe is really important. You know, it's really easy to slip off the vessel. So make sure you're anchoring your hand properly. And then that will lead to more accurate results. So just continuing on, so more factors that can affect the ABPI. If the Doppler signal is very quiet, it can be really tempting to push the probe into the skin to try and get closer to the vessel. And this actually impinges the vessel and may stop the flow altogether. So if the correct probe is attached, the ultrasound will penetrate far enough to pick up the blood flow. If it is quiet, then you can use headphones to provide to enhance the signal, and you should be able to hear that more clearly. So prolonged or repeated inflation of the cuff can cause venous congestion, and that can make it more difficult to hear the sounds and affect the accuracy of the readings. If there's any uncertainty during the procedure, just deflate the cuff completely, move on to the next limb and come back to it. Give the limb chance to rest and recover. And it's also just remembering that the ABPI is just very much a practical skill. And the more you do it, the easier it gets. When you're starting out, if you've got two people to do it, that is really helpful because you're doing two things at once. You've got your Doppler in one hand and you've got your Svig in the other hand. So just while you're getting used to that process, if two of you can do it, it does make it a lot easier. And then once you've done a few, you'll find your own pattern and your own positioning, the best way to do it for you. So we're just going to cover a little bit on Doppler waveforms, as this is part of your 3 Ps assessment. It's the second of your 3 Ps. So we've already mentioned that the ABPI can sometimes be unreliable, and this is primarily due to the presence of arterial calcification. If the ABPI is low, we can trust that it's low, but when it's high, we need to question why. Does the patient fit any of the health profiles that make calcification more likely? And analysis of Doppler waveforms can provide an additional form of assessment in such cases. So this clip shows a normal triphasic Doppler waveform. So you can see the visual there, you've got forward and reverse flow, and there's also a third phase there. I've recently been converted to using headphones thanks to my colleague Steve, who showed me that you can actually hear the forward and reverse flow in your left and your right ear, which is really, really handy. So we're just going to have a listen to a triphasic pulse. Okay, so that's a nice healthy artery. So it's like a train, da-da-da, da-da-da, da-da-da. So the next clip shows a biphasic waveform. You can see there you've lost that third phase, but that's quite normal in the aging process. So let's have a listen to that one. Okay, so you're hearing two sounds there. Wow. So this clip shows a normal, abnormal monophasic waveform. So you can see visually it looks very different. You've got more flattened humps there. And I'm just going to play this for you, and you can see that it does sometimes sound very similar to a vein. You've got that sort of whooshy sound to it. Okay, so you're hearing more of a wow, 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 a little bit of pulsatility there, but it can sometimes sound similar to a vein. So you'd normally expect that to be accompanied by a low ABPI, unless there's calcification present, in which case you might get a high ABPI. So what we're going to do now, we're going to ask you just to have a listen to this pulse, and we want you to say whether you think it's tri, bi, or monophasic. So you're hearing three sounds, two sounds, or one sound. So you're not going to see any visual with this, so you're going to need to listen carefully. So I think probably the best thing to do is maybe put your answers in the chat, see if we can do that. So let's see if I can play that for you now. So what do you think that is? Do you think that's a triphasic, a biphasic, or a monophasic pulse? I'll see if I can play that again for you.
Yeah, there's a lot coming through, Kerry. A lot of biphasics and some monophasics.
Amazing, thanks, Gab.
The majority is biphasic.
Okay.
So far, yeah.
Okay, answers still coming in?
They're still coming in, yeah.
Okay, we'll just give it a second longer, and then we'll do the big reveal. Okay, you ready for the big reveal? Sorry, I can't see the chat, so I don't know what's coming in. Right, let's show you what that actually is. So it's actually a monophasic pulse. So yeah, it was a tricky one, that one. It wasn't as clear as the previous monophasic pulse that we played. So you could almost hear two sounds there. And I know when I first heard it, I thought it was a biphasic pulse. But you can see, if you look at the visual there, you can see the loss of reverse flow. There's nothing below the baseline there, which indicates it's a monophasic pulse and a diseased artery. So yeah, an interesting one. What was you going to say, Gab?
Audio only can be quite subjective. So even the experienced person on those borderlines, it can be quite difficult to interpret.
Yeah, absolutely. I think you're right there. And I think it wasn't until I came to Huntley that I started using the visual Doppler. And yeah, I think previously I probably would have recorded that sound as a dampened biphasic, but yeah, having the visual does actually help you to differentiate between those. It is good. So if you can get your hands on one of those, it certainly does help. Okay, so just as we draw to a close, just a few cautions with ABPI. So firstly, it sounds really obvious, but ask your patient, is there any reason why you can't apply a blood pressure cuff? Let them guide you. Obvious contraindication is acute DVT. However, once your patient's anticoagulated and they're ambulatory, you can do an ABPI. And it may be the case that you do need to assess them for stockings. If there's severe edema, consider the fragility of the skin. Would applying a cuff cause more damage? And patients with impaired cognition and involuntary movements could make it very difficult to do an ABPI. So that's the end of the slides. So I think if you just remember your 3 Ps, your pulses, your phases, and your pressures. So your ABPI sits within that, within the context of what you're seeing clinically, in combination with a thorough history taking. So there we are. I hope that was helpful. I can see Kieran's just come back into picture there. So
thank you, Kerry, and thank you, Gavin. Yeah, a very informative session. I'm sure everyone on the call will agree. We've had lots of questions throughout the chat, a couple in the Q&A. If you do have a question that you've not yet submitted, please enter it in the chat box and we'll get through as many questions as time allows. If you could pop to the next slide, please, Kerry.
Yeah, of course.
There you go. So while people are thinking of questions, so yeah, this is our second webinar of 2025, and I'm pleased to confirm that we'll be delivering more education throughout the year. So please keep an eye out on our webinar registration page. This is available at wms.co.uk for future events. And yeah, as an attendee of this session, you'll also be notified of any future Williams Medical events. So from a Williams Medical perspective, as one of the leading partners for healthcare professionals in primary care, we are dedicated to supporting your everyday. This is both from a service perspective and also through added value and education, as we've been able to deliver in partnership with Kerry, Gavin and Huntley today. Our offering spans across numerous medical services, along with thousands of products in our disposables, pharmaceutical and equipment categories. We're very proud of our excellent rating on Trustpilot and just want to reiterate that we're here to support you and help you save time and effort with our omni-channel shopping experience. Next slide, please, Kerry. So as a partner of Huntley, I just want to highlight the range of products that are available at Williams Medical, including the Dopplers and accessories highlighted during the session today. Information on these products will be included in our post-event communications. And I'm also pleased to offer all webinar attendees an extra 10% off selected Dopplers until the end of March. You just need to use the code Huntley10 at checkout. Next slide, please, Kerry. And finally, I'm really excited to introduce Williams Plus. This is our new reward scheme at Williams Medical. We launched this scheme in November, and Williams Plus allows you to earn rewards every time you shop, and you can find out more about eligibility and enroll by visiting wms.co.uk/Williams Plus. Okay, so I think we can bring, if there's no other questions, I think we can bring the session to a close. So once again, thank you, Kerry, thank you, Gavin, and thank you all for joining us today. As I said, we'll be following up with resources over the coming days. And yeah, please don't hesitate to contact us or Huntley if you need any support. So yeah, we look forward to seeing you all on more webinars throughout the year, and enjoy the rest of the day and have a great weekend.
Thank you.
Thank you. Bye.
Bye.